of put it into context for you, I kind of start by this, so what is this person thinking? I'm a 25-year-old African American man, went to the emergency room for my second episode of severe back pain, graduated from a community college, have a part-time job, still waiting to get health insurance. My cell phone is my major computer, but video games are my biggest hobby. I'm not really a political person, but my parents remind me about their past struggles. I've heard the stories about how black people were mistreated in research, but I personally have no recent experience to draw on for that. My sister works at the local hospital. She likes it okay, doesn't say anything bad about the experience, wishes the pay was better. And I points out in this person that when they're going to be asked to join a study or become engaged in some of our research efforts, they're taking all of this experience and information and trying to turn that into a decision. Am I in on this or not? And we'll maybe go back to this person a little bit later. So you heard I'm from Johns Hopkins Hospital. This is a photo of our complex, and if you haven't been in East Baltimore, it's a large complex, and right over the tops of those buildings, you see East Baltimore. And East Baltimore has been a challenged community, particularly in the last 20 years when Bethlehem Steel left. The auto workers went down. It really hurt that community. We have probably 30% empty housing in that area. I think Johns Hopkins has a lot of experience related to community engagement because I don't think you're going to find too many academic health centers where really you go across the street and you are in a residential area. And that over the last 100 years has created a lot of ways where the community and the academic health center has to work together, and also strong views on who's benefited and whether it's been a positive relationship or not. And remember, this is what also is happening. This is Johns Hopkins. This is the map of all the locations for the Johns Hopkins health system now. So we have 5 hospitals, we have 4 large ambulatory centers. I didn't put on, the sites for our community physician practices, and I think this reflects the fact that academic health centers have been growing so much over the last 10 years, and that it's been even more difficult for the community members to understand it, to determine what their role is, and to make help to make them a judgment that is that academic health center here to help me, the community, and really move the translational research that we talk about here. So, how has the environment changed? And I would say, well, this isn't true for every academic health center, that academic health centers have generally prospered through the recent national recession. We're now maybe feeling some challenges about what the budgets are going to look like, but compared to many businesses over the last 5 years, academic health centers have done fairly well. They've grown in size to, in many ways, become the major healthcare provider. So if you looked at 30, 40 years ago, you may have had the academic health center, which was the research teaching academic. You had other large providers of care, and patients could make a choice. They could necessarily see the difference. Now, with the growth of the academic health centers, it's been even more, I think, confusing to participants about, is this the healthcare provider? Is this the teaching academic center? The non-for-profit status of academic health centers is being challenged. I don't think it's been a huge issue here yet, but as academic centers have grown in some of their for-profit activities, it's become somewhat confused. I don't know if any of you are from the Pittsburgh area, but it's where there's the major war between UPMC and the Blue Cross of Pennsylvania. And interestingly, there the ads are, many of them, talking about how UPMC has benefited from their non-for-profit status over the last 20 years and what have they given back to the community. I think we have to remember that in general, there's a lot of people in the United States that don't trust scientists right now. And we see that in some of the public polling around, if we go back to the issue of evolution, we go to climate change, we go in general, we're very focused on the evidence base for making decisions, but we have to recognize that there's at least a significant minority of the population that doesn't see that in the same way. And then, in general, federal funding has decreased, so partnering with for-profit organizations is becoming more common. And it's the good and bad of what we're trying to do. We like partnerships, and I think that's what translational research is all about, is partnerships. But for someone that's coming at, seeing this for the first time from the outside, to try to understand this complexity and weigh it and understand where it's going, it becomes quite a challenge. Disparities in healthcare outcomes are recognized more broadly. I don't think that there is anybody that would look at the American healthcare system and say, if we're going to meet our promise for the public, if we don't address the issue about disparity in healthcare outcomes, not only do we really fall short in terms of our commitment to the population and whatever concepts of justice, but the reality is we're not going to get the outcomes that we are either required to achieve as a healthcare system or as a community. And I think in general, none of us feel as proud about what we do when we see the disparities in the healthcare outcomes. So consequently, expectations for research in healthcare are ever higher. I think that's, it's good. I always do point out that even on the healthcare disparities, it's great that healthcare takes on that challenge of resolving it, but there's many, many segments of our society where they don't even attempt to say we're going to get equal outcomes for everybody in the population. And somehow in medicine and in healthcare, we've taken that on. That's fine. I think the other component where I also think we need to address is that for those that focus on research, the clinical care in terms of process, investment, safety, all of those have definitely gone up a level. And I think we're going to be challenged to see if research can come up to that level in terms of process, outcome, safety to what's being asked for on the clinical side. And then I think at the end, patients are taking more control of their health care and of what they expect from the researchers across the world, really. And you see that in some of these very faster cures is one example, but other organizations that are bringing together community and patient groups, and they are, the phrase, and I think it's a good one, who is in charge of the cure of my disease? And again, they have one idea, I need my disease to be cured, and the world is too complex for me to understand, how to achieve that. And I think the one group where I see it very clearly is, the Alzheimer's group, where you're seeing a big push on that. And in the Alzheimer's community, they see something like, okay, pharma invests in a medication that to address this. We have had a series of failures in Alzheimer's drugs, and so what happens is a lot of the pharmaceutical companies say, well, this is too complicated, we're moving on to another area. The patients say, I still have that disease. The They look at NIH funding, and again, it seems to vary federally, whether it addresses Alzheimer's disease or not. You saw there was an extra 100 million given in this year's budget for Alzheimer's, and then you have the situation where who is the biggest payer for Alzheimer's care? It's CMS. CMS does not have the ability to do research grants, and the patients are saying, I don't get this. I mean, CMS pays for it. They'll directly benefit it. Why can't they direct their funds? They see this complexity, and I don't doubt why they ask that question. Who's in charge of the cure of my disease, and how do I make that happen? So, in that context of seeing all this, where does the community begin to say, what are they expecting of the academic health centers? Well, the first thing is I don't think communities in general differentiate the parts of large academic centers. And this is probably more true of Johns Hopkins than others because of our size and complexity. So the community, I always say there's only a handful of people at Johns Hopkins that know all the different parts of it, right? So if this is the School of Public Health or the School of Nursing or the health system, the community sees Johns Hopkins there, and they expect us to act in a coherent fashion. And I think that's true of most of how communities see academic health centers. And while I'm all for reaching out to the community and say, let's work on and the more community participatory approach, that's let's start from the beginning, what's the problem, what we can do. If you can't help those people in the community get access to their medical care or others, you lose your credibility right away, because that's what they need to face today. The community expects equal regard for the healthcare experience of everyone. Fortunately, at Hopkins, we haven't had to address the issue of closing a hospital or a center in a low-income neighborhood. I know some other systems are trying to deal with that, and that's very difficult. And so I think what they do, the community does expect that everyone has access, that the research portfolio of that institution reflects the community, and they can understand how that works. That the healthcare team, and I put that broadly, the healthcare team, the research team looks like them. They need to feel that there is some representation, something that they can understand. And while it's never going to be perfect, you have to recognize that that's what they see. Participation in decisions about the academic health centers, particularly if the decisions impact them. We've been doing several community programs. I'll talk to you later about the Henrietta Lacks issue that we've dealt with, and we just did with about 200 individuals, asked them about Hopkins, and many times they said things like, will you help me understand how Johns Hopkins makes decisions, because it's a mystery to me in general. And I think the more, sometimes we're afraid to open up the doors about how, and the windows of how we make decisions, but the more we bring people into the decision process, how do we decide to put resources here and not there? Why did we decide we couldn't go with this relationship or others? The more we bring them in, the more they understand where the decision is, and they're more willing to support those decisions. And that's the second part, communicate the real story around decisions. There's so much of that the community sees that they don't understand, and then inevitably when there's a vacuum, they make up that story about why the decision was made. Recognition that communities include multiple voices. We try to make it simple and try to say one person speaks for the community, or if we take care of this group in the community, we have done a good job with community engagement. And the reality is that particularly in the United States, we are a very diverse country with diverse views, and I think what seems, that's when we hear the focus on individualized healthcare, it's because of that. It's because we recognize that diversity, and we have to show that in our policies as well. A sustained focus on solving their problems, and I'm going to mention this before. It's the sustained issue for it, and many people, particularly the community leaders that we deal with, have generally been in those communities for years. And it's also a reality that in some of our health systems and academic health systems, people tend to come and go. And I think you have to really handle those transitions, even if it is sustained, when they see a person that they've been working with for 5 years or 6 years or 7 years, and then they, for very good reasons, leave to go to another institution. You have to recognize that that's a problem, and how do you create that continuity? And I do think that's in some ways where what we call our ICTR or your CTR has that role to provide that continuity that the community sees and that will manage those transitions. And they expect new effective approaches to prevent and cure their problems that the community can access. And I point on that the community can access, or our mission statement for ICTR, that we create interventions that are consistent with the values of our community. And I think in both of those ways, there is nothing more frustrating than for a community or an academic health center to develop a new intervention that's only available to people that are in the HMO and not for that community. Or to develop a new, be part of the process of developing a new drug, and it is, so expensive that a very few people can access it, or not universally being accessed. And so I think that's the way I would always think about it. And we have plenty of examples. I mean, I can just give you one where we think is a positive story, but I can understand where the community would have some problems with it, and it reflects the complexity of the world. So we've had a group that have developed. This is really in behavior. It's an obesity management program, which is both telephone and internet-based. We worked with community practices. It was very successful. It was called the Power Trial. It was published in the New England Journal. We said, well, this is great. How do we take this intervention now and broaden it? And we found a Healthways partner, which is a national disease management chain that helped pay for it, have been partnering excellent about, fidelity and making sure that this program matches. But of course, the way Health Partners provides that access is through their managed care contracts. And it turns out that most of the people in the Baltimore region don't have the access to that program through their HMO. In fact, even our own employees did not have access to it in the beginning. So here we were very pleased that we took a program, and in a few minutes it would reach 10 million Americans, and they were partnering and paying for fidelity, but it didn't hit the target population that was around Johns Hopkins. And we are trying to work through that issue. This is where I'm saying it helps for us to at least explain to the community of patients and the overall community how we got to this place, but it doesn't necessarily solve the problem. So are academic health centers meeting their expectations from the community in this area? I started by saying it's not really easy to know if we are meeting the community's expectations, or if your centers are doing a better job than our centers. And that's a problem, right? It would be nice if we had some better metrics to really know. And we're all working on those, whether those are metrics that look at the impact of the research that you do, to what extent does it go from a publication to more widespread. We don't have common measures of how the public, our patients, our communities see us. We've become involved in the development and utilizing a survey that routinely assesses satisfaction for research participants that are in our study. And I personally have found that very helpful, and there's some benchmarking with it, but it is not with two other institutions. But we don't have a system right now that really requires it. We don't have anything like HCAHPS in the hospital system that would tend to look at that. So even on that basic level of are we satisfying participants in terms of those that work with us in research, we don't know. Some academic health centers are taking on responsibility for the health of populations, either through managed Medicaid or ACOs or others. I believe that this is an important step. This is clearly where we say that we are with you 100% in terms of getting to the best that you can with your health care. And our community engagement program has been involved. We have one of the CMS innovation grants, which is saying we agree to take care of the patients in the 3 zip codes around Johns Hopkins and Bayview Medical Center. And it's interesting to us because somehow we're going to reach out to patients in those zip codes that are not yet patients at Johns Hopkins and say, we want to take responsibility for your health. We're doing the measures. We're trying to do this. And it has to be in a respectful way, because I think all of you can imagine that probably 75% of the patients around Johns Hopkins use Johns Hopkins facilities, and the 25% that don't have a good reason why they don't use Johns Hopkins, and they don't necessarily want to be automatically enrolled in any of our plans. But again, I go back to limited objective measures to judge healthcare systems in terms of how they're doing. And I think that's where it creates a little bit of a problem, where I can go to a community forum and say, yes, Johns Hopkins, we're doing this and that, and we've done everything, and they're still not satisfied, or they're overly satisfied, and I think when you don't have measures that you can look at, then there's not the incentive for the healthcare systems to actually do a better job. They don't get any thanks, they don't get any competitive advantage sometimes, because they can't really prove that they're doing a better job with the community engagement and translation. So, what is community engagement? And I think you'll see multiple examples of this, but this is the definition that we use: the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar structures to address issues affecting the well-being of these people. And I think when you're going to see, you're all in the enthusiasm phase for translational research, and that's great, and we have to sustain it, but it's way up here, and then you have to kind of narrow it down and specify it, that people can kind of get their arms around it and say, what are we going to do? But I do think ultimately all of translation is around building new relationships and new partnerships. And you can see it from the drug development side to the community engagement and policy. And I also think you have to recognize, for everybody, when you build a partnership, it does kind of take them out of their comfort zone. That's what we're supposed to be doing, because everybody gets really good at what they do in a limited sense. And they say, I can just keep doing this over and over and over again because I'm comfortable here, whether it's on the basic science side or the policy side, or people that do the community engagement. They say, well, I don't really need to know about any of the basic science stuff and what's going to really work, because I'm real happy just staying in that comfort zone. So every time when you're doing translation, you're asking somebody to engage with somebody new and say, how do I speak the vocabulary, understand, get to that common understanding that's going to make this work. And remember, when you ask somebody to go out of their comfort zone, they see a huge opportunity cost in learning. They say, all right, I'm really going to have to learn new skills. It's going to take me some time. No partnership gets, working like that. It takes that commitment and time, and our job is to provide the vision for them about why it's worth that time and effort. And that's what we have to do, I think, over and over again. Why you're going to, at the end, feel like you've accomplished more, because there's nobody working in this area that at the time they retire do not want to feel like they've accomplished something and made a difference in somebody's life. I really think that's true. When we do our surveys of people, that the basic scientists that work in their labs, at the end of the day, they want to feel like what they've discovered has changed somebody's life. We're finding this we have 3 translational research communities that we have decided to build because they do have some unique aspects. So one is focused on drug development and biologics. The second one is focused on biomarkers and diagnostic tests. And the third is on behavioral and social systems. There are a lot of people in the behavioral side that are just as frustrated, that say, I showed a program that worked. It worked for in my setting, it worked, and I didn't know how to then get from that small setting to disseminate it to the larger community to make a big difference. All right. So this is where I'm going to try to get you a little bit more specific, because you got to start focusing relatively soon on what parts of this translational pathway you're going to make a difference in. And this is just 5 functions for community engagement and research that I would help you think about. And I'm going to now go into these with a little bit more detail. So deciding on the research question. So you can spend time, and I think all of us need to spend some time learning about and prioritizing the major health problems in the community. I don't know that we need to spend a huge amount of time. I've seen too many efforts where identifying which is the top problem has been a multi-year process, and I'm not sure that we're at a much different place than when we started. And I actually think that to some extent it's more on what's the approach to solving the problem than actually determining which of these many diseases is our major problem. But we have to learn to use both quantitative and qualitative data from the community to get their input. So where does a survey or more objective process have a role, and then what can we do just interviewing the key leaders, the patients, the stakeholders, to more quickly get to the heart of the problem. And then this examining the research portfolio of the academic health center. It's a tough issue. We do it with our community engagement board. I think it deserves at least once a year that says, oh, we're not doing any research on smoking cessation, but we're doing, $200 million of research on multiple sclerosis. I'm not saying that, just saying that's the type of, judgments you have to make. And it is useful, I think, to make sure that the common problems or the most important problems are getting the right attention in the broadest terms. Then developing the research protocol. So consulting the community early in the process, so we are evaluating interventions that make sense for the community. That's where I think it's really, we want to do something about reducing obesity in this community. We've decided on that. Let's really take some time to say which of these approaches makes sense to who and why. Considering stakeholder input on sustainability at the earliest stage. Part of that is getting their commitment. If you bring in, the state, the insurers, others, if they're determining which program we're going to look at, and we've done everything that they said in the research that is going to help them make a decision, that commits them to take action based on the research at the end. And if they come in after the fact, I think you've all had experience with this. Well, you didn't measure this. You didn't measure that. It wasn't long enough term. It didn't look at out-of-pocket costs, whatever it was. And then there's a reason why they're not invested in implementing the decision. Incorporating community assets to the extent possible, I think, is something that researchers are not usually aware of, and the community can be very helpful with. Identifying successful strategies for recruitment and follow-up. All of our studies develop, if you're going to do a study, you might as well get the highest quality evidence you can out of it. When there is difficulty getting patients enrolled and doing the follow-up, we all suffer. Whoever's invested in that research is not getting their value back. And communities are often very good at helping us understand how to do the best with recruitment, how you frame the problem, frame the study, get the recruitment, and help us understand what the major barriers are and how you might at least address them. And then making a determination about the ethical acceptability of the protocol. That can happen obviously at the IRB level, where we have federal regulations. We know there's community input, but the Community Research Advisory Board also can have a very key role in that. We use our board frequently for that, to provide that sounding board. And the one thing I will say was, I go on to how you have to make sure that the community members have the right background training to make those decisions. One of the mistakes we made early on this is we had some protocols that were pretty difficult ethically, and with those interventions without consent that require community input formally. And frankly, the community was like, this is a really hard decision to make. I don't know if I can say that this study can go forward without consent as the first task. And we really had to back off on them. Our timeline was we needed a decision. They were saying, I'm not really ready to make that type of decision for the community. Conducting the research, assisting with publicity and recruitment. What is that? What's that outreach to let individuals understand? The first step we always have to overcome in recruitment is just basic communication about the availability of a study and how that works. Identifying acceptable informed consent processes. We use our Community Research Advisory Board for that as well. Measure and evaluate research participant satisfaction. I think that's important. I think that getting the input from those that participate about what's important, I think is very useful. I know on our side where our satisfaction level was very high on, did they trust the staff? Were they treated with respect? All of those. Where we didn't do as well are things. The research team promised the results would go to my clinical providers. I didn't know who to call when I had a question. Again, to me, for us, it's always how to get that individual patient to understand how to work with a very complex organization, and it's our job to simplify what they see in a way that they can make sense of it and make a contribution. Help research participants complete study, transportation, babysitting services, all of those that are very helpful. Community input on data and safety monitoring boards. The data and safety monitoring boards do not have any requirements for community input. They're oftentimes just scientists, just data experts, but they're making decisions that impact on the community. We're going to stop this trial because of futility. We don't think we'll ever get an answer to this because of the recruitment and the community may have a different value on how they on how they determine futility than a group of scientists. Community input on how long observational studies should continue. And I really think we need to think this through again about, we all are aware of the Tuskegee trial and what an impact that had on how the public saw research, but there are difficult issues with that. How long do you do surveys on finding whether people are still smoking without trying to really help them to stop smoking? How long do you follow a cohort of patients with hepatitis C before you say, we have a great treatment for hepatitis C now, and even if you have challenges with your insurance, we're going to make sure you get treatment. Analyzing the results. How are results presented for subgroups? I mean, we're really focusing on that. Is it always best to present results by, by race, which is so frequently done, or by gender, or are there better measures that describe what these patient subgroups are that are not just by race, which may not even be a self-determined variable? How are the results presented by sites? You've seen that. You have 5 sites. 2 sites are in poor neighborhoods. The other sites are, and somehow it comes out, well, it didn't work in these 2 sites with poor communities, but it worked in the other sites. And the community had no input to say, well, this is why it didn't work at our site. How is not adherence described and accounted for? We frequently, well, this is a group that didn't follow the protocol, so we couldn't look at it, without really taking into account the factors that lead some groups to not be able to follow protocols as well. And then who owns the data for the analysis? If you haven't hit this yet, it is coming. It's this notion that I'm only signing up for a study if I own that data, and that means after it's published, I get to decide whether it's republished or given to other scientists, groups for those that are able to make the next step with the data. And I've personally having to deal with this a couple times in the last month, and it's not something that we're all prepared for. Disseminating research findings, right? Publication is just the beginning of maximizing the impact. How do we communicate the findings to those who participated in the study? If you ask the people in studies what's the biggest reason why they won't participate in another study, it is because they said, I never heard about the results of the last study. When they sign the consent form, they're told this is the most important study that's ever been conceived of. And then when the study's over, they never hear the results. And I actually think for our community engagement program, that's now becoming one of the top priorities. Help investigators to get the results back to those that participated and the community. Identify stakeholders needed to support sustainability, including community organizations early. You could do a whole community engagement project around that says, here are, we have a finding that's coming up. Let's see if we can't mobilize those individuals that are going to be needed for sustainability. And I put this at the end, that the academic health centers have to lead in changing practice based on results. This does not work if you say this study finds that this intervention is much better, and then you tell all the community hospitals and the insurers and everybody else it's your job, implement it first, while the academic health center is lagging on it. We have to show leadership of this learning healthcare system if we're going to have credibility. So those you can look back, those are just very specific things that are part of the community engagement process that you could decide to focus on. And here's one model of increasing level of community involvement, impact, trust, and communication flow that has been used in several of the CDC handbooks. I think is fairly helpful that you can begin with outreach to the community, some community involvement, you give some information, but the entities really coexist, right? We're outreaching the community, but you're different. Then you get more into consultation, where there's community that flows from the community into the academic health centers. You're beginning to develop at least very much like we use consultants in our health system too. So at least we're getting the information in. Involvement, where there's more information flow both ways. There's more participation with community in the developing the issues. The entities really cooperate with each other fully. Then hopefully we get towards collaboration, where there's a structure for this byflow of communication. There's much more trust between it, and then finally at the end, to the extent that you can get to a shared leadership component, that here is the funding, the resources or whatever, and there is equal participation between the community and the academic health center. That takes years to accomplish, but I think that's the vision that we want to have. And every time when we make a decision about where those resources going to be placed, you want to have in mind where you're heading. I'm not going to talk about the biospecimens for us right now, but I want to talk about what we've learned from the Johns Hopkins Community Engagement Program, for what we've been doing over the last couple of years. So, build capacity in the community to understand research principles. I liked Michael when he flew through the slides, and we got to look at that. I also know that when it really comes to decision making, if you don't understand what a placebo-controlled trial is, or what is T2 or T3 or T4, you're left out of the conversation. And these principles take some time, but it's not like the community cannot learn this. There's no way it's building some of that it's taking the time to build some shared vocabulary. The other issue that I think it's really, to me, quite interesting is anybody that are in the community organizations, they're being asked when they're trying to get funding from grants from different state or city organizations, they're told they have to have an evaluation section in their grants to know whether their program works. That's good, but it also it's a great opportunity to partner with them, because they're like saying, I don't really know how to put an evaluation plan together that's going to get me the information I want, that has some methodology, some rigor to it. So I think you will benefit highly by doing something like a community leadership program. We have different names for it, but whether it's workshops, or I know a few CTSs have community academies where they take a cohort of community leaders through a full year. Transparency in decisions. I know we say this and it comes up, but it is a real issue, particularly for the community looking in. You have to make it clear how you major decisions, particularly whether it's pilot grant, who gets engaged on the board, how you for example, I'll tell you another one that I know really irks our community advisory board. When a researcher sends them something 1 hour before the meeting or the night before. And we had to really enforce this. It has helped tremendously. The leader of our community research group meets with that faculty member. If you do not have that material at least 7 days before the board meeting, don't come, because we are not, we're not going to just pretend like we participated in the decision. We need to really have the information and think it through. Target long-term relationships. I just can't emphasize that enough. Grants are short-term, relationships are long-term, and I think all of us have to remind ourselves of that every day. Ask for diverse opinions from the community and not be too rigid about representation. I don't think it really works if you try to say, well, this is who my community is. I need 2 from this neighborhood and 1 for this. And the one thing that I will say at Hopkins, though, we did decide, how we have I showed you multiple hospitals. There cannot be one community research advisory board for Hopkins. It's too big. We focus on some different areas, saying we're going to need multiple community research advisory councils, and we ask everybody on the board, and the good people that are on the board know it. They're going to say, I'm talking as an individual now, or I'm talking for the community to the best extent that I know it and can represent it. And I think you always want to encourage that. The last thing I want to just talk about is take advantage of high-profile stories to engage the community. And, at Hopkins, we have our share of controversy. When I go to the community, what I keep saying is we don't shy away from the tough issues. We don't always do it right. We certainly don't do it right the first time. But if we don't say we're not going to take care of of low-income individuals. We're not going to do this with the Medicaid. We're not going to engage with for-profit companies. We're going to say, we have to do this. We won't get it right the first time. We're going to continue to try to do that. And one of the high-profile stories, which certainly something as I took my job I had to deal with, was this book, The Immortal Life of Henrietta Lacks. How many here have heard of this book? Yeah, it's amazingly, it is a story that, and if you talk about any story that has engaged the community about how to think about biomedical research in the last 5 years, it has been the Henrietta Lacks story. Just to, to give you that quick summary, she was a patient at Johns Hopkins in 1951. At the time, there was no informed research consent done. She signed a surgical consent. The cells were taken. They have become the immortal cells. They're probably the most important cell line that has been developed. They were, yes, used to, create the polio vaccine, to go up in space to see the first time whether cells could survive. They have been used by multiple private entities to create very profitable products, and the family did not benefit financially from any of that. And I do think if you look at that, and this is where, again, I would say the ICTR has been important. That story was percolating around Baltimore for 20 years. A story here or there, never crystallized until this book. And there was nobody at Johns Hopkins that said, "Oh, that's what I do," right? It was a little bit, I'm supposed to be that outreach, that link, how to turn that story into a opportunity to engage the community on the issues and move ahead with it. And so when this came out, the book, the university and Johns Hopkins said, well, this is what the CTSA is supposed to be doing. And we have taken it on, quite successfully. We have a Henrietta Lacks Day once a year that we get 800 or 900 people there now. We fill Turner Auditorium. It's our approach to say, look, these are tough issues. This is where I'm saying, when you go to the community and say, I understand that the Lacks family did not benefit financially for it. I must have had this question myself 100 times. Every time I go to talk about Henrietta Lacks, I get somebody who says, why hasn't the Lacks family made any money off of this? And we go through, what would it mean to do that? At the time, in 1950s, Johns Hopkins gave away everything. That's how we did it. And while the community doesn't understand that, as soon as I said, at Johns Hopkins, we spend $100,000 a year buying the HeLa cells for our research from the companies that produce them and, make whatever money it is around it, it made sense. And we've used it to really, during these days, to engage community. What does the IRB mean? What does tech transfer mean? How do you do that? This book, the Henrietta Lacks book, is required reading in all the Baltimore City high schools now. We just brought in the top 25 students from all of the high schools in Baltimore for a one-day event around this, and they had the best questions, frankly, of any of the questions I've gotten. We turn it into an art show where people come, and we've had a national competition about what are your best pictures of HeLa cells. This is our historical timeline in the hospital about what has been accomplished at Johns Hopkins, and Henrietta Lacks' story is part of it. This is the Henrietta Lacks family that is next to the plaque that we put right in the lobby of where most of our basic scientists go up to the lab to work with the HeLa cells. And to see the Lacks family, the transformation of that family to be a proponent of medical research and to say, I'm going to, just, I don't know what I would say. They downplay, they don't focus so much on the financial aspects of their ethical, or what happened in 1951, and say, I'm going to champion the impact of what my mother, grandmother has had on the world has been, in my view, nothing, less than outstanding. And it's a huge role model to the community about why participating in research is tough, it's a sacrifice, why we thank you every single day for your willingness to contribute, and why in this complicated capitalist world we live in, the finances don't always flow back directly to the patient that may have contributed. So I'm just going back to, what is this person thinking about? We said this before, and I tried to really focus on those young and middle-aged participants in our community, because I think they're the ones that we really need to make sure that they're forming the right attitudes, impression, willingness to work. And, I go back to them and say, well, I had severe hypertension. They asked me to join a study, provide a blood sample, and receive care in one of the academic health center's outpatient center. And I want to make sure that when that person is being faced with that idea, they have the right, attitudes going in, they have the right information they need to make that decision, and they have the right understanding about what research can accomplish for them, and that when we do that, what the promise is between the community, the research participants, and the researchers to make sure what's done in that study has as big an impact as possible. So that's a little bit of our look at what we've been trying to accomplish. And do we have time for a few questions? Okay, thank you.
with community engagement, with community engagement. It is, okay. With community engagement and partnership, what pieces of that are going to change? We can see probably some changes in the outcomes or the process of research that you've talked about. Safety, how are those things going to be measured? And do you think that those things are ever going to be measured in the way as with a health system, sort of your payment, your reimbursement, and a lot of that is becoming dependent on those things? Is research funding going to be more demanding of what has been non-traditional outcomes for research?
Yeah, so let me, what she was asking this question about that comment I made about, is the conduct of research going to be as safe and as the highest standards that we may see on the clinical side? And let me, and it may be a little bit harder concept to, I probably should have said more to help people understand it. But I guess I would say, and I'll give you a prime example to help maybe make this clear. So at Hopkins, I had our board of trustees agree to a statement that says, at Johns Hopkins, all research will be done at the same level of quality and safety as care that's being done in the clinical center. And you might say, well, of course, research has always been safer. But, in today's environment, I'm not always sure that's true, because in some sense, we all are facing real limitations on research funding, and there is the temptation sometimes to allow the research to be done in a setting where we might not be willing to say that we would do this clinically. And I'll give you a very clear example right now. We have a study which is trying to look at a new method for alcohol detoxification. And the study, it should be inpatient. And we, you probably know, inpatient research these days is quite expensive, and the NIH does not fully fund that. And we have, hospital days that, cost $1,500 or so, 100 participants, it adds up pretty quick. So the temptation was to say, well, maybe we could do this as an outpatient. So what we said, well, if someone presented to our emergency room and said they wanted alcohol detoxification and they were at the same level that we're talking about in the study, they would be admitted. And so we said, okay, we're not going to do that's our promise to the community. If that's what it would be clinically, then that's what we have to do on the research side, and we have to find a way to fund that. The other issue where this has come up, we worked a lot with the Community Research Advisory Board, is conducting research within the clinical care environment, particularly around the electronic medical record. And we've made the decision that we're going to incorporate as much of our research data into the electronic medical record as possible, because it directly addresses that concern that says, my doctors didn't know what happened in the research study. They never got the reports. They never got what happened on that echo or the MRI or whatever. Now you realize when you put the research data into the clinical record, there are going to be some people that don't like it, right? I mean, I absolutely acknowledge this. There are 10 or 20% of patients that say, I'm only going to participate in a substance abuse or HIV study if my data is totally confidential. I think that's a small number. This is where I said, how do you deal with the diversity of opinions in the community? I went to the Community Research Board, several of them. I said, look, I have to make a decision on this. Are we going to put all the data in the EMR, recognizing that some people may have the potential for harm because of it, but that we believe that 90% are going to benefit because what happened in the research is going to be known to the clinical providers. They're going to be able to implement that and make a difference. And so at the end of the day, after I felt more confident that I had the community input on that side, I said, this is the way we're going to do that. And we've had to restructure our consent form to make sure that people know when they join a study at Johns Hopkins, they are going to potentially have some information in the electronic medical record which they may not have perfect control over, as if we know the rules on that for anything of what we're doing right now, right?
Yeah, I'd appreciate a few comments, and the context with which I'm going to ask the question is, it was really entertaining to see the slides about how tobacco studies over the years furthered the evidence about how cigarette smoking was impacting public health in America and across the world. And those studies, if you looked at the dates, there were years apart. And we know, if we think about it, there were tens and maybe even hundreds of thousands of folks who were dying and suffering terribly during the time when the evidence was building and the policy interventions were starting to take hold. And really that period was 30 to 40 years. So to organizations that are looking at obesity and hypertension and how we're going to change the population health markers around those issues today, what do you say to us?
Well, yes, you definitely see the tobacco evidence was a journey, right? And it took some time. It's easy to look back and think that we did know everything. If you go back to that first 1964 Surgeon General's report, they only said that cigarette smoking was connected with lung cancer. They wouldn't say heart disease or anything else because the evidence at that time was not as good. And, the odds ratio for tobacco and lung cancer is in the 13 range, and for, cardiovascular disease, it's in the 2 range. So it did take some time. And while it is true we made a lot of decisions, using observational data without a randomized clinical trial. We did not have a randomized clinical trial that told people who smoke versus non-smoke. We did do a couple finally on reduction, right? So we randomized smokers, not. It does point out that the level of the evidence, when it's observational and multiple confounders, I've spent 2 days as an expert witness with the tobacco company when OSHA was trying to do their indoor air pollution regulations. So I know exactly how they try to tear apart each individual study. So I do think there was some issues of bringing on the evidence. But the public, I hope, this is where I said expectations are going up. We are expecting, all of us, and you can look at the tobacco. It's not just healthcare settings, right? You had to get the policymakers on board, both on the economic front and regulations. And we have higher expectations that we're going to take this evidence, change things more quickly. I think a lot of it is creating this urgency to change, which is not always easy. It's all of us have a lot to do in